Oral Health in Maryland. This is a virtual task force meeting, so I ask for your patience if we encounter any technological or streaming issues. Before we begin, I remind the task force members that this meeting is being streamed on the Maryland General Assembly's YouTube channel. Task force members will be muted throughout this briefing. If you have a question, please use the raise hand feature on Zoom. I will call on members to ask questions. After I call your name, please wait a moment while staff unmutes your screen. We'll begin our meeting today by going through introductions of the task force members and then review the charter legislation, including a discussion of our anticipated timeline to achieve the interim and final reports set by legislation. Then we will receive a presentation by Nancy Brown, who is a policy analyst with the Maryland Medicaid Office of Innovation, Research and Development. This presentation will be followed by a Q&A session. At the end of this meeting, we will have an opportunity to discuss next steps and action items for this group. Please keep in mind this meeting is scheduled to conclude by 4 o'clock. And with that, I will begin the introductions for myself while we await Dean Reynolds from the Maryland School of Dentistry. I'm Alex Schiffler. I am the co-chair of this task force along with Dean Reynolds. I am at the Office of Medical Benefits Management here at the Maryland Department of Health and senior advisor to the Medicaid director. Both the Dean and I have had opportunities to speak with the task force members and look forward to our work together over the next several months. With that, if the Dean is on, I do not see him. I will proceed with introductions, and once the Dean joins, I will give him an opportunity to make some comments and introduce himself as well. So in no particular order, we'll start with Mary, if you would.
Sure. Good afternoon. My name is Mary Backley. I'm the CEO of the Maryland Dental Action Coalition, a statewide network of individuals and organizations working together to improve oral and overall health through oral health promotion, disease prevention, education, advocacy, and access to oral care. I'm delighted to be on this task force. Thank you.
Thank you very much. Jennifer Bremen.
Hi, good afternoon, everyone. I'm Jennifer Bremen. I'm Executive Director of the Maryland MCO Association. The association represents the 9 MCOs that serve the 1.4 million Marylanders enrolled in the Health Choice program. We're grateful to have a seat at the table. I'd like to thank Alex and Dean Reynolds for their time and leadership of the task force, and happy to be here today. Thanks, Alex.
Thank you. Anna.
Hi, I'm Anna Davis, and I am representing Advocates for Children and Youth, which is a statewide organization that advocates on behalf of children in the state of Maryland. And I'm very, very happy to be on this task force and to participate. Thanks.
Thank you. Dr. Woodward.
Good afternoon, everyone. I'm Brooks Woodward. I'm Director of Dental Services at Chase Brexton Healthcare, which is one of Maryland's federally qualified community health centers. Thank you.
Thank you. Dr. Carlson.
Hi, I'm Dr. Jean Carlson. I'm here representing the Maryland Association of Community Colleges. I teach at Chesapeake College in Y Mills, Maryland, and we have several community colleges in the state that have dental programs, dental assisting, dental hygiene programs. So I'm here to represent those. I'm privileged to be on the task force. Thank you.
Dr. Hughes.
Hi, good afternoon. I'm Debony Hughes. I am the Director of the Office of Oral Health within the Maryland Department of Health.
Thank you. Christy?
Good afternoon. My name is Christy Russell. I am the Director of Operations for the Maryland Developmental Disabilities Council. We are a statewide advocacy organization that creates change to make it possible for people with developmental disabilities to live the lives they want with the support they need. Thank you for having me.
Thank you. MJ.
Good afternoon, everyone. I'm MJ Kraskow. I'm representing MAP, Maryland Against Poverty. We're a group of coalition members that advocate for policies to positively impact individuals living in poverty and low-income individuals. Happy to be here and looking forward to working with everyone. Thank you.
Thank you. Sarah.
Hi, good afternoon. Sorry about that. There was a pause. I'm Sarah Ches. I'm the lead hygienist for Choptank Community Health, another FQHC. I'm part of the school-based program that travels to Caroline County, Dorchester County, Talbot County, and now we've added Queen Anne's County and Kent County schools to provide dental services.
Thank you. Dr. Kimbers.
Hi, good afternoon, everyone. Looking forward to working with everyone. I'm a general practice dentist for many, many years. Won't go into that, but I've served the underserved community for many years, and I look forward to assisting in any way I can. Thank you.
Dr. Dow.
Thank you. Good afternoon. I am Emily Dow. I'm the Assistant Secretary for Academic Affairs at the Maryland Higher Education Commission, MHEC. We are the state agency that regulates and coordinates post-secondary education in Maryland. So we work very closely with all the colleges, universities, and our non-degree granting private career schools. Thank you very much. Look forward to working with you all.
Thank you. Dr. Coman.
Hi, thank you for having me here. My name is Hakan Koyman. I'm a pediatric dentist, and also I am the dental director for Maryland Healthy Smiles in the state of Maryland. I'm excited to be here and looking forward to working with everybody. Thank you.
Thank you. Dean.
Hi, my name is Dean Schiffler. I'm the managing client partner at DentaQuest. I oversee the adult dental plans that are in Maryland, DC, and Virginia. I also oversee Pennsylvania and Ohio, where there's both dental for both children and adults.
Thank you. Dr. Doring.
Thank you for having me. Charles Doring, I'm a general dentist in Rockville, Maryland. I am here representing the Maryland State Dental Association. We're the state arm of the American Dental Association. I'm their Legislative Affairs Committee Chair. I'm also, along with Dr. Kimbers and Dr. Koyman, a member of the Maryland Healthy Smiles Provider Advisory Board. So I do treat a fair number of patients under the Maryland Healthy Smiles. I also see patients at local nursing facilities, homebound patients as well. Thank you.
Thank you. Dr. Verma.
Good afternoon, everyone. My name is Arpana Verma. I'm a practicing general dentist in Frederick, Maryland. I'm also the current president of the Maryland State Board of Dental Examiners. Our mandate is to provide and protect the public in dental healthcare settings, to license and discipline as needed dental healthcare providers. I'm looking forward to representing the board here, and I'm happy to meet everyone.
Thank you. Dr. Romain.
Hi, everyone. I am Dr. Diane Romain. I'm a general practicing dentist in Frostburg, Maryland. I currently serve as president of the Maryland State Dental Association Foundation, who does a lot of Mission of Mercy projects across the state. And to that reason, I was appointed to the commission just with that history in my background. I'm past president of the Maryland State Dental Association and excited to work with everybody.
Thank you. Suhani.
Good afternoon. My name is Suhani, and I'm the Government Relations Associate with Public Policy Partners. And we work closely with Mary and the Maryland Dental Action Coalition to advocate for oral health across Maryland.
Dr. Carlson. I got Dr. Carlson, I apologize. I'll go to Dean Reynolds since he's had an opportunity to join, and then I'd like to invite Delegate Magnol to offer some comments as well.
Good afternoon, everyone. I think I'm off mute. Thank you for being part of this task force and joining for the others that are joining. I serve as Dean of the School of Dentistry.
Great, and I believe we were missing a couple of task force members, but Delegate Magnol, we'd invite you to make some comments to our inaugural meeting.
Thank you so much, and I apologize. I'm going to be mostly off camera. I just got off the road, but I did want to say thank you, everyone, for being here. I'm Delegate Magnol. I'm a member of the Health and Government Operations Committee, first-time legislator since 2019, and the House sponsor of the Oral Health Task Force bill. And I'm just very, very excited to see this work begin. I know it has been many, many years in the making. So thank you so much for giving me the opportunity to be a part of this process.
Thank you. So having gone through doing a little roll call, and we again will fall missing a couple of members, but we'll have an opportunity to speak with them in the future. I'd like to start by reviewing our charter legislation. So rather than going line by line, and perhaps staff can put it up, I'll do the summary of our charter of our mandate for the next several months. And the task force is a culmination, as Delegate Magnol noted, of a lot of work on the General Assembly's part in terms of focusing on oral health and improving oral health for all Marylanders. And as summarized in the task force, we have a number of different elements that we're seeking to address. Analyzing the current access to dental services in the state with a focus on the socioeconomic status, race, ethnicity, age, and disability of residents as factors impacting access to dental services. Identifying areas of the state where a significant number of residents are not receiving oral health services, distinguishing between pediatric and adult populations, identifying barriers to receiving dental services in areas in need, analyzing the specific impact of such barriers, assessing options to eliminate such barriers, including the feasibility of establishing a program for dental therapy in the state, and making recommendations to increase access to dental services in the state. So a fairly broad mandate in terms of what we are seeking to accomplish and the deliverable that we intend on providing to the General Assembly to potentially offer a roadmap to these asks, if you will. And I know that the Dean and I have had a chance with the staff in terms of some of the pre-work. We previewed this with you all in various individual meetings, that what we're hoping to do for the deliverables that we have, which as a reminder are an interim report, and staff correct me again if I'm off, due in May of 2022. And then that's an interim report, and then a final report due to the legislature in December. So we have an interim report that comes up fairly quickly, especially given the timelines related to the next session starting in January, and then a final report that will be due at the end of next year. Am I wrong on any of those dates? Okay. And the Dean and I, what we're hoping to do, given the large number of stakeholders and the variety of folks that we have on board, is to offer very clear and concise, as granular as possible, definitions and recommendations to the General Assembly to address these various issues. We expect there to be a number of sub-work groups that we'd like to discuss with you all in terms of how those would form and participation and so forth to get through the meat of the work. And as such, we have previewed and thought of, and before we memorialize them and share them with the groups who want to open up for conversation to discuss how these subgroups might form. Right now, the subgroups that we anticipate forming that seem to naturally capture the mandate in the charter of our legislation would be coverage, vis-a-vis insurance coverage. We have a number of payers in the state that provide dental services or some sort of benefit that we want to focus on where we may be impactful there. Socioeconomic and racial discriminatory barriers to oral health in the state that we would like to tackle. Geographic disparities, geographic barriers to access to oral health services, given the dynamic that we have in the state of a large rural population and a large urban population. I believe, if I recall, based on our rural access, only 9 to 10 of our 24 counties are considered urban or suburban, the rest are rural. So we have a dichotomy there. And then the last bucket, and then I'll invite the dean to also offer some thoughts, is workforce development. We have a number of a variety of practitioners that are represented on this task force, and to look at the leveraging the assets that we have in place, the programs that we have in place to tackle each one of these issues. And as such, we have, and after we've had a little more conversation, we've started to invite various stakeholders to come provide a baseline of information. You'll hear from the Maryland Medicaid Office of Innovation, Research and Development here at the end of our end of this conversation. We will have in future presentations. We're hoping to have presentations from the Office of Oral Health, as well as the Programmatic Administration for our Healthy Smiles program and so forth, to provide baseline data and information to our task force to help inform our deliberations. And with that, I'll offer Dean Reynolds a chance to speak about his expectations and hopes for the work of this task force.
Alex, thank you very much. I think you've really captured the essence. We, again, as Alex pointed out, have tried to not only look at the charge to the task force, but look at how we could break out to efficiently gather data. And I think, as Alex pointed out, to the extent possible, what we would like to do are make recommendations that are specific, but that also are based on evidence that's currently available either within the state or that we might be able to extrapolate from other states. And workforce development is an example of where we do have other models that we can look to, and I'm assuming that we will be able to learn a great deal from others' experiences. So I'll stop there, Alex. I think you've captured it. Will you speak to the process or first, I guess we should open up for just a general discussion for the subgroups?
Yeah, I would open up at this point. I'd want to hear from the task force members before we have the presentation, because I know there'll be lots of questions and follow-up items that we might want to tackle. Give the task force members opportunities to weigh in on what we've spoken about during this session, as well as the concepts of these various subgroups or buckets, if you will, to try to add a work plan into for the broad mandate of the task force. If there's other suggestions for subgroups that you think would be appropriate, we'd like to have that conversation now with the larger group. So as a reminder, please do the raise your hand feature so that our support staff can help to facilitate the dialogue and unmic folks as well.
Thank you. I really appreciate the agenda that's been created for the subgroups. I think I may take the liberty of speaking a little bit for everyone in that I think once we have a lot more information that we're trying to collect, we would have a lot more opinions on where to go with this. I think that this is a good breakdown to start with, and we're likely to have a lot more thoughts as we go along. So I'm looking forward to the presentation, and I thank you for taking the time to put this together.
Dr. Hughes?
Could you give us a little background on how the pots were developed, the buckets were developed?
So this is an attempt to capture the various items that are embedded in legislation. Legislation is a culmination of a number of activities through sessions that predate my time at the department. And in order to try to place them in manageable packets for which we could assign task force members, we decided to start off with our suggestions in terms of where we should start as a starting point. And that's why we have these open to expand upon those buckets, if you will. And then obviously, as we assign staff, or I should say task force members to each one of the subgroups, we'll talk about the mechanics behind that after the presentation. We will be open to expanding upon them as well. But these buckets, if you will, capture most of what the charters that we've been presented with. If you have suggestions for other ones, though, this is where we appreciate the dialogue for additional areas. And again, this will be iterative that we might want to contemplate. And what we'll do is once we kind of get more of this feedback, we will provide the descriptions of the subgroups for the future meetings and for assignment purposes. So we'll open that up via various communications and make assignments, and then we'll try to get those subgroups established and begin their work. Those also notably would be subject to the Open Meetings Act and would be recorded and participating as well. You have a follow-up, Dr. Hughes, or does that answer your question?
You answered my question. Thank you.
Go with Dr. Doring and then Dr. Romain. Dr. Doring.
I can appreciate the buckets, if you will, but I do think there has to be some silo busting. Just to give you an example, if you look at geographic barriers, say Western Maryland or Eastern Shore, and then you got to cross over to workforce development. It's fine to train, thousands of dental auxiliaries, but if we don't have a mechanism to get them to go to more underserved areas, we still got the problem. So there has to be cross work within the various buckets. Thank you.
Yeah, and absolutely. And I expect obviously, given the vast number of stakeholders we have, the subgroups would report back out into the larger group. And for example, if we're talking about workforce development, incentives built into workforce development in terms of in order to attract members of various professionals into various underserved areas that would touch upon. And by bringing these subgroups in and their work and presentations into a larger group, we can look for areas of synergy and kind of task that way. Everyone will have visibility into everyone else's work.
Absolutely. If I may, I'm sorry, Dr. Romain, if I may just interject, Dr. Doran, you're absolutely spot on. And there was no intention here to silo in that sense. It was just strictly, we know we need information in these areas to help inform recommendations. And so your point is very well taken. This is just really content areas where we need to better understand the current state and where we might look to the future. Thank you. Dr. Romain, I apologize for cutting you off.
No, so as coming from a rural area, I often see sometimes the barriers to care in rural areas can be similar to cities and that they're greatly financially based. So there is a lot of crossover. Just in my experience of being a Medicaid provider, I think Medicaid could be its own bucket. I mean, there's so much there to really explore so many people that, I think Medicaid for seniors who are dual eligibles would be great. There's a lot there. And so I would say looking at the workload in the buckets, maybe we could look at what the mandates are again, and then try to look at how those mandates would fit into 4 areas that would have kind of similar workloads in them and have a nice crossover with the groups.
That's Dr. Romain. And again, one thing to make note about, kind of our charter, Medicaid is going to be your biggest lever inside of Maryland. Obviously, the health benefit exchange can be slightly different in terms of where we can effectuate. However, we're not restricted to contemplation of just changes to government-sponsored programs. Obviously, Medicare is off the table. That's not what we're going to effectuate. They're already dealing with their contemplation of how they're going to offer oral health benefits in budget reconciliation language down in Washington. But potential recommendations is not too far afield for minimum benefit thresholds in insurance inside of Maryland, depending upon the marketplaces. Small individual, there's a lot of overlap in those marketplaces. As you see with obviously the exchange and Medicaid being one side of the fence or the other, as I described them, and very similarly for smaller group market, individual group markets. So we could very well, in terms of coverage, break out that bucket to Medicaid as well as non-government or sponsored insurance, if that's something that the task force feels that we should. And again, everyone has access to the charter legislation, and with Delegate Magnol on here can give us a little bit of a legislative history, which is always what we do to interpret legislation in terms of where we can go. Again, these were a starting point. The charter, what we're looking at, is very broad. In order to start be able to break it down, we established those buckets. Dr. Romain, do you have a follow-up on that?
No, I was just going to say, like, and particularly for seniors, I know more and more seniors in Maryland are buying into the Medicare Part C extra benefits. And I think that would be really an important part to go over in when we look at coverage, how seniors buy into Medicare Part C, how is Medicare Part C for seniors in Maryland?
Yeah, I mean, absolutely. I mean, obviously, Medicare C, Medicare Advantage, the feds run our relationship in terms of what we effectuate as a regulator is really is restricted only to the DSNP market, or the dual eligible special needs market, which is a nascent space here in Maryland that a lot of our insurers are beginning to explore. But in terms of background information, absolutely, given the fact that Medicare is always going to be a primary and Medicaid would be secondary if you have a dual eligible, and for those who, but we can certainly in future presentations, invite that kind of background information. And after we have our presentation from IRD, we will talk more about the baseline information that we would like to bring to the task force members to help inform. We've had conversations about inviting the Maryland Insurance Administration, as well as other state agencies, as well as other stakeholders that would be relevant to our deliberations, and again, invite conversation about who those should be, since we all need information that will be provided from the staff as well as outside experts. Other folks, before we decide to turn it over to our my colleagues from IRD? Okay, with that, then Nancy, I invite you to make an introduction before you present your material, and then given the fact that we have a lot of members, I'd ask that task force members reserve their questions to the end of the presentation to ask Nancy.
Great. Good afternoon, everyone. My name is Nancy Brown, and I'm a division chief within the Office of Innovation, Research, and Development, which sits within our Maryland Medicaid program. I'm here today to present on our 2020 annual Oral Health JCR Joint Chairman's Report, which is a report that we do every year. If you happen to be at the, I think it was the February Maryland Medicaid Advisory Committee meeting, a lot of this content is going to look familiar to you. But if you weren't there, it'll all be new. So next slide, please. So just as a quick agenda, I'm going to be giving a quick overview of our dental program. We'll then be going into the dentists and Medicaid. Then we'll be talking about our dental utilization, our adult dental pilot program, our COVID-19 response, and then some other more recent updates. Next slide. So our Maryland Medicaid dental program, as I'm sure most of you already know, is called Maryland Healthy Smiles, and participants are assigned a dental home upon enrollment. That program serves pregnant women and children enrolled in Medicaid, as well as adults in our REM program. Additionally, all 9 of our MCOs voluntarily cover limited adult dental services to their own members as part of their profits, as part of using their own profits. So it's not a benefit that Maryland Medicaid itself is reimbursing for. In January of 2017, we began reimbursing dental services for former foster care youth up to age 26. And in June of 2019, we started our adult dental pilot program. So I have a lot of slides with a lot of numbers on them, and I'm not going to be reading every single number because that would take a long time. So I'm really going to be focusing on the numbers from 2019. So this is our first slide is the number of dentists who participated in Medicaid who billed for services by year. So as you can see, over time, the number of dentists billing has increased. In calendar year 2019, we had 1,694 unique dentists who billed Medicaid. And the 2 highest regions where we had dentists billing were our Baltimore metro area and then our Washington suburban region. Next slide. And again, this is another slide with all of our participating dentists. So in 2019, the total number of active dentists was about 4,229. Of those, 240 were pediatric dentists. 1,738 dentists were enrolled in our Healthy Smiles program. And then again, 1,694 billed for services. And of those 1,694, 1,244 billed $10,000 or more of services. So now we're going to switch to the utilization. So this is the number and percentage of children ages 4 through 20 enrolled in Medicaid for at least 320 days receiving dental services. So in 2019, we had 477,768 total children that met this criteria. Of those, 331,485 received one or more dental services. 323,449 received a diagnostic service. 304,816 received a preventive service. And then 109,887 received a restorative visit. Okay, so if you can turn your head to the left a little bit, this is children ages 0 through 20 enrolled in Medicaid for any period. So it's a different cohort of children who had at least one dental visit by age group. And you can really tell that over the years, we've had an increase in percentage of children receiving dental visits. So in 2019, we had 56.7 children overall receiving some sort of dental visit, and our 6 to 9-year-old children had the highest percent utilization with 70.7. So this is the same cohort of children. But this data is those who have received a preventive and diagnostic visit followed by a restorative visit. So we had 408,862 children in 2019 with a preventive or diagnostic visit, and that's about 55.8%. And then 28.3% of those had a restorative visit. So you could really see that over time, the percent of those with a preventive or diagnostic visit has increased, and the percent of those with a restorative visit afterwards has decreased. So now we're going to switch to pregnant women. So this is the number and percentage of pregnant women ages 21 and older with at least 90 days in Medicaid who had a dental service. And as you can see, over time, the percent has increased. So we're now approaching 29% in calendar year 2019. And overall, there were 28,939 women and 8,346 had a dental visit. And this is the same, a very similar graph, except it's enrolled for any period in Medicaid. So you can see it sort of follows the same trend. But overall, we had 33,961 pregnant women and 9,675 had a dental visit, which is about 28.5%. So now we're going to switch gears a little bit. This is our REM population. So this is participants ages 4 through 64 with at least 320 days in Medicaid who had a dental service. So in calendar year 2019, we had 3,959 participants that were in our REM program. And of those, 2,306 had a dental visit. And again, our highest utilization is in our 6 to 9 year olds. Now switching gears a little bit again, this is now our former foster care participants. So this is enrolled for any period in Medicaid, and this is by region. So overall, 20% of the former foster care youth had a diagnostic visit, 15% had a preventive service, and then finally 6.4 had a restorative service. And our highest utilization is in the Eastern Shore. And then this is our non-pregnant adults. So this is that MCO population where the MCOs voluntarily cover a benefit. So in 2019, we had 16.2% of those participants receiving a dental visit, which amounts to 93,998 participants. And so this is a different table, but it's for ED visits. So it's the ages 0 through 64 with at least one ED visit with a dental diagnosis or procedure code. So we had 17,342 participants with an ED visit with a dental diagnosis or procedure code, which is about 1.2%. And that amounts to 39,306 visits. And our 10 to 14 year olds is the group with the lowest percent visits. So now we're going to switch gears to talk about one of our newest programs, which is the Adult Dental Pilot Program. So in 2018, the Maryland State Legislature passed Senate Bill 284, which required the Maryland Department of Health to apply for a waiver to CMS to implement an adult dental pilot program. And we received that approval in March of 2019 and began operating the program in June of 2019. So the statewide pilot serves duly eligible adults ages 21 through 64. It covers a limited dental benefit package, but it does include diagnostic, preventive, and limited restorative services, as well as extractions. Skygen USA administers the benefit like they administer our other benefits for dental. And then the benefit, unlike our other programs, however, the adult dental pilot program beneficiaries are subject to an $800 per person maximum benefit allowance per calendar year. Next slide. Okay, thank you. Prior to each visit, so the provider must verify a participant's eligibility and the amount remaining in their maximum benefit allowance by phone or by web portal. And at each visit, providers and participants must sign a global treatment plan. The provider must review recommended services and costs. Participants will then make an informed decision about services they wish to receive. And then a copy of that treatment plan must be given to the member and then also filed in their chart. Providers should also submit claims immediately after rendering services because claims will be reimbursed in the order that they are received. So Skygen will pay the amount remaining in the benefit allowance up to $800 per participant each calendar year, and any request above $800 will be denied. And then finally, providers can charge members with a signed non-covered services agreement. So that must be signed prior to rendering services, and it's similar to the global treatment plan. It must outline the specific services to be provided as well as the costs. And the member must sign it if agreeing to pay for services out of pocket. So this is the data that we have on that pilot so far. But as a reminder, because this pilot started in June of 2019, this is really only 7 months of data and not a full 12-month period. So in that first 7 months, 12.2% or 4,508 participants received a dental visit. 11.8% had a diagnostic visit, 6.3% had a preventive visit, and then finally 3.6% had a restorative visit. And as you all know, COVID-19 has been around since March of 2020. And in response to that pandemic, we've made some updates to our billing codes for our telehealth program, and that includes dentists. So we began offering Tele Dentistry starting on March 5th, 2020. We are currently conducting a review of all the codes that have been appropriate, that will be appropriate to continue after the pandemic. And we're still working on that analysis. Next slide. And then some other recent updates. On January 1st, 2021, we began offering dental services for postpartum women. So currently women are eligible for Medicaid 60 days after birth, but we're also going to start working on extending that period so that women will be eligible for a full year after giving birth. On January 1st, 2022, we'll be doing a removal of some certain frequency limitations for cleaning services. And that was a bill that was passed this past year. It was House Bill 547 and Senate Bill 485. And then finally, in early 2022, the 2021 version of this report will be released. We're currently working on it, getting it finalized right now. And with that, I included links in the presentation to the report that I'm referenced in this presentation, as well as to our reports and publications page, which has all of the reports that we've previously done. I think that goes back all the way to 2009 for this report. And then finally, just a link to our Healthy Smiles page. And with that, I'm happy to take any questions.
Thank you, Nancy. If staff could get go back to the exit out of the present. There we go. Thank you. Please raise your hand if you have questions you'd like to ask Nancy.
Looks like Dr. Romain might have a question, or was just thanking for the presentation.
No, I appreciate it. I have a question actually. I am a provider who does a lot of pregnant women, Nancy, and I have tried to submit claims for pregnant women after they deliver, and they have not gone through. So are you saying that they should have as of January 1st? That was a point of clarification for me because I haven't experienced that.
I believe that they're supposed to be going through, but I can double check and take that back.
We'll go with Mary and then Christy. Mary, please.
Thank you. And thank you, Nancy. The results on the adult dental pilot program, you said it was 7 months and not 12 months. So that slide, that would take it through December of 2019.
Yes.
Okay. Are there updated statistics available for the task force on the utilization through 2020?
We are currently working on our 2021 version of this report, and that will include the 2020 calendar year data. We are seeing some decreases in utilization throughout due to COVID-19.
Sure. Thank you.
Christy.
Thank you. And thank you, Nancy. I just have a question. I'm looking at slide 7, where it shows the percentage of children ages 0 through 20 who are enrolled in Medicaid and have at least one dental visit. And it looks like the age 19 to 20 population declines. And then we have the adult pilot program who has a limit of $800 for services per year. I'm just interested to know if we have information about why there's declining visit rates for the 19 to 20 population. And then if there is a declining visit rate for that population, do we know if there are attempts to receive services in excess of that $800 threshold because they aren't getting the preventative care that they need or services that they need because they're not using the service when they're 19 to 20. Does that make sense?
It does make sense.
Great,
so for our adult dental pilot program, it's really for adults with both Medicare and Medicaid. So it's really a subset of the population, and largely those children, if they're 21 years old and on Medicare and Medicaid, they're largely disabled. So it's not quite the same population transitioning from having Medicaid dental coverage as a child to this program. But we can certainly try and look into why that decrease happens. I believe it's largely because certain eligibility changes as somebody switches from being a head of household and becomes an adult rather than being in their children's program.
Yeah, I'd just be interested to see if there's a correlation then with oral health in that adult pilot program.
Yeah.
Thank you.
Emily.
Thank you. My question comes from my background is not in dentistry, so I apologize if so I don't know if this is a question for Nancy or just a general question for the work group that should be tabled. Do you have any sense? So not everybody who's eligible to take advantage of these services is taking advantage of these services. Do you have any sense why? Are there collections on that? I would imagine some of the practitioners maybe on here could speak to that in terms of why we're not seeing closer or more expansive taking advantage. I'll stop.
No, that's a good question. So we have been seeing increases in utilization each year, probably 2020 as an exception. But we work with SkyGen to make sure that people are getting sent welcome packets when they become eligible for our dental service. And we're doing a lot of different outreach activities within the department, as well as the Office of Oral Health does also a lot of outreach activities to get people into needed dental services.
Dr. Doring.
I've heard statistics, and the ADA may be able to verify this, that if you look at the overall general population, about 50% have seen their dentist within the past 12 months. And you're looking at all socioeconomic backgrounds. So it's going to be hard to get 100% all the time. I would say some of the statistics are looking at middle age and say after the wisdom teeth are removed. So early 20s into your 30s, we see a decrease because there's a less perceived need for dental care. And that's something we're going to need to address overall. So we can look towards American Dental Association for some kind of stats on that.
Delegate Magnol.
Thank you. And this is just a quick question because I know that we are challenged now with the fact that we are trying to do this work and collect data and compare it with numbers that are skewed by COVID. So are you able to adapt at all and sort of look at it through a telehealth lens, which we've not really done in the past, but is sort of demanded of where we are? I know that in the somatic care and in the mental health care arenas, we've actually started that data collection to try and identify what's working. And I know I would suspect in the dental field it's quite different, but there is still that utilization. And does it look like that's going to be part of the workload, or is this just going to be sort of an anomaly?
That's a really good question. So I know CMS has been looking at teledentistry and a lot of the telehealth utilization over time in the Medicaid program. And I do believe that while we have seen an increase in teledentistry so far, however, that's still it's not the same as, there's still a gap between the number of teledentistry visits and the number of visits that you would expect to see in a given year. So it's not fully addressing the unmet need due to COVID.
Dr. Coman.
Thank you. I was just gonna go to Dr. Dow's question about utilization. And, we actually, when you look at it, I mean, I think when you crunch the numbers, it's about 69% of kids actually did have some sort of visit at a dentist. So, I mean, utilization was pretty good in this state. But I think, I think that was the hope behind this program too, is what is it that's causing, those barriers to care? And, because, and I've always said it is, the one difference is because most of this population is pediatric in nature. And so unfortunately they can't drive to their own appointments, make their own appointments. And it's interesting because I think when you get to that 19, 20 and you get that fall off again, it's because all of a sudden, perhaps, the responses or the responsibilities on them, but it'll be interesting to see as we work through this. But I feel like a lot of it kind of has a lot of education component too, but we'll see as we kind of work through it, I think. Sorry, but I just wanted to say that.
Thank you. Dr. Doring, you have a follow-up.
Yes, I would just want to address the delegate's question on the telehealth, teledentistry. I do use telehealth, and particularly in communicating with nursing home staff and long-term care facilities. And I use it primarily for triaging and also for follow-up. If someone can send me a picture, I can kind of triage how urgent that person needs to come in. But I will tell you, in the height of COVID-19, when we were shut down, I had a patient. She retracted with spoons, and I could see her very, very well. And I said, you really have an issue where you need to come in. I think you've cracked the tooth. So, there were only so much we can do without actually seeing the patient in our operatory and taking an X-ray. But it is a tool in the toolbox to help us.
Thank you. Other questions for Nancy? Dr. Verma? I see you, Raven.
That's all right, no worries. I guess I have a utilization question. I am curious, out of all of the eligible participants, is there some type of backlog on assignment to providers, or is that not a barrier that's a current issue?
I don't believe that's a barrier that's a current issue, but SkyGen would probably be in a better position to confirm that.
Dr. Coman.
Sorry, and just speaking from SkyGen, yeah, there's no backlog right now as far as assigning providers.
And
assigning not providers, but participants.
I would note that just as to interject here, that one of the things, and we'll talk about this here in a moment, that we intend on doing is having another presentation from the staff that administer the Healthy Smiles program and administer that have oversight over the administrative dental ASO, and we would inviting them to make a presentation in our next session, as well as the Office of Oral Health. So some of these questions you can reserve or refresh and ask again on the next meeting as well. Sorry, I didn't mean to interrupt the flow. Other folks have questions? Yeah, please use the.
I just kind of had a statement. Being in the schools and working with the students during COVID, I would go back to our clinics, and the greatest barrier, I think, to care for me that I would see, a lot of these kids, it's transportation. They don't have a way to get to the clinic, and the parent doesn't have a way to get to the clinic, and this gets, those cavities and everything I see just gets worse and worse every year without that transportation.
Thank you. Yeah, we might be able to, again, as we kind of scope out what we're going to talk about in presentation, more data, talk about the NEMT, non-emergency medical transport benefit that we have as part of Medicaid, what restrictions we have there, where we may leverage it, not, as well as other state-sponsored programs. Dr. Hughes.
This probably is a question that I should save, but I just wanted to highlight that it seems like our pregnant women population has the lowest utilization. And I would just like to know, once they find out that they're pregnant, how they're informed about the services that are available to them, because it seems like, I don't know, do they know that the services are available, and what are the efforts being made to make sure that they get into care?
If I could respond to that a little bit, I think one of the issues too is when a woman finds out that she's pregnant, she's not coming in quickly for services. So some of our providers really aren't finding out that a woman is pregnant until she's 6 months in or later in her pregnancy. So there's less time to be able to get her in to get a dental visit when she has so many other things going on.
Christy.
Thank you. My question is actually similar to the previous question. I was just wondering how information was provided to adults who are receiving the dental services through their MCOs. Is that information that the MCO is providing, or is that information found elsewhere?
That is information that the MCO is providing. We really don't have, we have it included on our MCO consumer comparison chart, what dental services they're offering, but really that's large, it's entirely the MCO's responsibility to offer those dental services, and they can change at any given time.
Yeah, if we indeed decide we want to go down a path where we want to talk about the different offerings out there in dental, whether or not it's in Maryland, Medicaid, Medicare choice, which is, again, we don't have influence per se on the benefit design, since that's voluntary with Medicare choice plans. We can talk about kind of the baselines. Obviously, in many of the cases, unless there's a defined benefit, it's offered as a supplemental benefit, something extra that's offered by the MCOs, whether that be Medicaid, certainly in Medicare, hence why there's a conversation right now in Washington about creating a fee-for-service dental benefit. It's all voluntary, as offered through Medicare Choice, Medicare Advantage now called. It was Medicare Choice back in my day. But we can have a conversation about that. Dr. Carlson.
Hi, I really just kind of have a comment here. Being a practicing dentist for many years and seeing Medicaid children since the late 2000s, I found that really the way a lot of the children patients would get to me was that their pediatrician was informing the parents that the child needed to have dental care. A lot of times the pediatricians would let the parents know that there was this program called Healthy Smiles. We had some practitioner. I'm here on the Eastern Shore, so access to care was and still is an issue. But some of the pediatricians were helping us out, and I think that is something that we should. That's a great relationship that dentistry needs to foster, is with the medical care, especially pediatricians, when we're talking about children. Thank you.
Thank you, Dr. Romain.
No, I agree with what the last questioner said. I mean, part of our mandate is looking at the oral systemic connection. And I just wanted to ask Nancy, your data is so detailed. Do you ever look at data of, say, Medicaid recipients who do engage in preventive care and how their costs go for their Medicaid healthcare? I think that could be an interesting opportunity. I know it's done in the private sector and some cost savings are realized. So is there an opportunity to look at it like that? And my second question would be I feel like so much of the data stops at 64. And I know those people aren't on Medicaid, but how much, Nancy, do you have access to finding data on people older than 64? Because I do think that's a population that goes to the ED and really struggles to get care.
So that's a great question. Those are two great questions. So every year we also release an annual health choice evaluation, which is our entire 1115 waiver, so it's a lot more programs than just our dental program. But we are working with CMS to develop a new 1115 evaluation, which will include maybe some potential studies on how the adult dental pilot program is working and what the costs associated with that are and how that's changing other related costs. But can you repeat your second question again? I'm sorry.
The second question is, so much of the data stops at 64. And there's a lot of people over 64, and those are the kind of patients I see in my practice every day. And in looking at their emergency department data, at least here in Allegheny County, they're the highest growing group going to the emergency department. So is there some way to look at their emergency department trends, even though they don't have a dental benefit, if they are, I don't know, I'm just asking.
So
data for older
the reason
folks,
a lot of our data stops at going through 64 is because once someone turns 65, they become eligible for Medicare. So then it sort of becomes an awkward, tricky issue, because most of the time, Maryland Medicaid is always the payer of last resort. So it becomes complicated trying to figure out the things for that age group.
Yeah, there's a Medicare well, again, Nancy can correct me if we're wrong. This is me putting my old policy hat on. There's a file for Medicare fee for service that you can look at, but obviously there's not going to be any encounter data or claims data for dental because it's not a covered benefit under Medicare. If you're in Medicare choice, where they offer some various degrees of coverage depending upon what they want to offer, since it's basically benefit rolling back in from what they did against the benchmark, what quantum of benefit they want to offer. It's all over the place, and we don't receive that encounter data because they are obviously Medicare regulated entities, and so we wouldn't be able to parse that out. That's to Nancy's point. It kind of adds additional color as to why there becomes a bit of a gap. We do have obviously access to CRC data and so forth, and that we will, some of which we're going to try to put into we already may have it in the a data library that the task force members have access to and should have access to, but we will capture that. Dr. Kimbers.
Seeing Medicaid patients since the early 80s, there's one problem that I've seen over and over again that really has not been addressed, and that is the missed appointment and just my time being not valuable to the patient, to the parent. The main thing. I mean, I give them 2, sometimes 3 times, to come, and they still won't bring the child, even for a root canal or, fillings, or much less the 6-month appointment for a cleaning. And I think that needs to be tackled in some way, shape, or form. My time is just not important to that patient population, it seems. And it's more times than not. Missed appointments.
Dr. Hughes and then Mary, please.
Okay, this is, I wanted to share a point of information regarding getting pediatricians involved. We have a fluoride varnish program that EPSDT pediatricians can apply fluoride varnish in their programs. And we recognize the importance because infants will see their pediatricians before they see a dentist. And so with these pediatricians applying fluoride varnish, the idea is that they will make the appropriate referrals to a dentist. So it's really an important engagement process. And currently we have about 500 participants. And that is one program that we're trying to increase and participation among pediatricians. And so we are working with the Academy of Pediatrics to help them inform their providers and let them know that the program exists and the importance of their involvement. That's one of the programs I'll be talking about in our presentation next month, but I just wanted to share that information since the question came up about pediatrician involvement.
Thank you, Mary.
Yes, thank you. I just want to go back to Nancy, the awareness with regards to the availability of services and addressing that in the context of the very low rates of utilization of dental care for pregnant women. Is there, since postpartum is coming down the pike, 60 days and 12 months, is there going to be some type of outreach either by the department or by SkyGen to make women aware of the eligibility as well as access to benefits to try and increase those rates?
I would ask that you defer and hold that question until we have the programmatic staff that'll intend on having present next week, as well as Dr. Hughes has been invited, or not next week. Let's check that next meeting, and we can have answer some of those questions.
Terrific.
For example, a question that was just asked, that Dr. Romain had asked previously about, I believe it was related to the postpartum coverage, and that becomes effective as soon as our regulations are promulgated, and they have to be published in the Maryland Register for 10 days. And that's when the benefit begins. So we're in that process of rolling out those regs, and that's when it becomes effective. But these are the types of questions that I would ask that our programmatic staff, our operations staff, could entertain when they present, along with Dr. Hughes, in separate presentations next time we convene.
Thank you.
My pleasure. Other questions? So at this point, having heard the dialogue thus far, I think, and what we'll do is we'll write up these additional buckets, send them off to the task force members to opine on and create extras. But hearing, again, no silos, starting point only, to be as inclusive as possible, but also not boil the ocean. Telehealth, I would suggest as a possible leveraging technology. We don't want to get into I would presume, and I would let the dean jump in here as well, presume to get too prescriptive about what we think should be covered and not covered. Some services, but not in terms of per se the too granular, but obviously entertain different platforms. Care coordination amongst providers, perhaps. And then education outreach seems to be a nice catch-all that we can be inclusive in terms of educating about the dental benefit, outreach to vulnerable populations that may not be availing themselves of this, and so forth. So those are 3 buckets that I would perhaps suggest add on to the other 4 that we're working with, and we'll write those up, provide brief abstracts on them, and then circulate them around. And again, they're iterative. Delegate Magnol, please.
Just from the conversations that we were having, I think also creative ways to leverage transportation and creative ways that we can meet that transportation gap, because I know that came up a few times. I'm not sure what that bucket would look like, but I think it's probably worth just keeping it on the radar.
Yeah, and as we talk about, in terms of the access, and that would transcend across, it would also address the geographic access issues we have, right? If there's a benefit and people can get to beyond the 30 miles, what I'll do is I'll follow up with the operations and programmatic staff here at the department to see if we can give a pretty good snapshot of NEMT as it relates to, and this is obviously the context of Medicaid, dental, as well as just a larger conversation about transportation. And I know that staff is listening to this task force conversation, so I'm sure they're writing this down to provide additional data points, if you will, for our work. Just to, while people ruminate on what they want to ask, the other things that I've gotten down that I think might be useful for folks, and again, our data and our ability to present a large landscape might be a little bit more limited, but there seems to be a great deal of interest in terms of other payers, what they're covering. And as a matter of fact, if you look at some of the draft legislation that's going around where they're talking about Medicare in Washington, and it's very much a mark, very preliminary, they're talking about, as they think about when they're creating fee schedules and so forth, they're looking at the Veterans Affairs Administration, Medicare Advantage, any other kind of outside data points that kind of fix on what they want to do. We can have those conversations about what other payers do right now rather than what they might get to. Again, this is a moving target, especially in the Medicare space. So I would want to just focus on what we know is working now and what is present now, perhaps just for our own edification, the Medicare Advantage market, insofar as we're able to find it. But again, that's going to be different across the country, be different inside of Maryland, depending upon what the choice programs offer the county, since they're offered on a county basis. But we'll see what we can drill into that to provide more information. I will take note also that we did, again, a lot of this we tried to do, I'll say pre-work, but try to find out where we could, where we could find little nuggets throughout the state. And we have asked our colleagues, the Maryland Insurance Administration, the actuaries there, to see if there's any kind of baseline data that they could have against the individual small group markets or large commercial markets. But again, because their offerings are fairly broad, there's not necessarily a baseline that we can look at. It's kind of divergent. But to that end, I would also now open it up to people's suggestions about stakeholders and other folks who might want to invite to come to present. So, for example, the largest insurers in the state and the commercial space, we want them to come in, the Alliance for Maryland Dental Plans, so on and so forth. Who do we want to come help to provide data to our committee, while recognizing that during the course of our meetings, their deliberations as well, we have to keep some time for our open dialogue with a number of folks that we have, as well as kind of grinding out the work. So I'll open that up as a larger invitation for suggestions.
Alex, if I could just add, I think, in coming back to the discussion about silos, I think in the end, we're charged with really looking broadly at access, areas and communities, populations that are underserved, and capturing really what are the barriers that are present. And barriers, of course, range from having benefits or insurance to transportation. And then finally, what are our recommendations? And so from my perspective, it makes it a little easier to begin the discussion of trying to first understand what the need is, why that need is present, and then what we might recommend. So I know a simplistic way, but I think that's the essence of the charge.
Dr. Romain.
I wanted to say that I know the Maryland State Dental Association, through the foundation, has really since 2009 been in touch with the Maryland HSCRC to get emergency department data based on age and payer and region by hospital. So I think the HSCRC, like you're saying, could be a big source. We have some of that already, and I know you all are doing a sharing Dropbox. So, we could share some of that. I think the American Dental Association Health Policy Institute also has a lot of state level data that's already there, and we could definitely collaborate with that. I know just last week I was talking to my colleague Cheryl Lerner, Dr. Cheryl Lerner, who heads up Care First Dental on the private sector. And she was saying how now like 50% of her seniors are doing the buy-ups for Medicare Part C. So I do think it'd be interesting to get some private sector data from, Care First or one of the other providers looking specifically at the Part C. I just keep perseverating on senior data because it's such a need. And I'd hate for us to not take action because we don't have the data. I think that would be not a good flow or a reason. So it's our responsibility to find something to inform some decisions that get seniors care. That would be important.
Yeah, and when I was talking about large insurers, actually referring to Care First in terms of perhaps having them invite. But again, in terms of senior coverage, that's going to be the feds paying for it. State dollars don't pay for medical care in dental. If there's some sort of possibility, there's always the possibilities of wraparound and so forth, but there's not a basic fee-for-service benefit to wrap around with right now, just Medicare choice, and that's a voluntary option that's offered in the Medicare space. Dr. Romain, you want to follow up?
Yeah, I just wondered, is it possible though, at least for seniors 133% and below the federal poverty level, to have them on Medicaid, like a dual eligible? Like, could we maybe think about as our discussion, would the pilot be appropriate to advance to, beyond 64?
Right. So what I would defer there is, and I know I'll ask that Nancy and the the dental squad led by the Deputy Director of our Acute Care Administration, Katie Narrow. They can talk about perhaps providing a snapshot of where we are on the dental pilot and then so forth. But again, Medicare is always going to be primary, Medicaid is going to be secondary. So there's going to be a wraparound potential option. And in terms of the dual eligibles outside of the pilot that we have for fee for service, if they are enrolled in a managed care advantage plan, then they're kind of there. We don't effectuate it or have any role to play unless it's in a DSNP dual eligible special needs plan space. But there and we can have people talk about that as well. But it's a little bit more, it's very nuanced in terms of where the feds begin and where the state ends and where the twain overlap. Dr. Coman.
If we're talking about potential speakers to come speak to us, which I believe that's what you asked, correct, Alex? I think a vital source of information would be the Academy of Pediatric Dentistry and their public policy, Paul Casamasimo, who, I mean, they have data on every Medicaid program across every state in the nation. And I mean, they have so much data that they can share. I think they would be an excellent resource for this group to see what's working, what's not, and to kind of just have some hard numbers with facts and things like that. So I think that would be a good one that we can probably get organized also.
Christy.
So in looking at who we are supposed to be, or what we're supposed to be looking at in terms of socioeconomic status, race, ethnicity, age, geography, disability, I wonder too, where are we pulling information from those stakeholders to make sure that the things that we come to as this task force are really representative of the people for whom decisions may be made for. With regard to this task force, I think that if we're talking about speakers, I don't know if that's in the plans to pull in stakeholders from each of those different groups, but I think that there should be an opportunity for people from each of those groups to provide input. And then I would also suggest that if we're looking at geography, we may want to pull in the local health departments, specifically from the more rural regions like the Eastern Shore, the Western Shore, or even some of those urban areas, because a lot of times local health department nurses work directly with people from each of those subsets of groups that may be able to provide information relative to their needs.
Thank you for that. And that kind of goes parlays, and I don't want to cut off the conversation, to the next steps and action items. Again, it's our first meeting inaugural. We did some work to provide some contours to the work that we need to do, given the fact that it is very broad. One of the things that the dean and I had thought, and obviously post to you all as well, is that every other meeting or every meeting, that there be a time allocated at the end for public comment. To invite stakeholders, members of the public to do so. Obviously, in the time of COVID, we're a little bit restricted to our in-person abilities, but in an ideal world, and perhaps we can do this as time progresses, as we move forward into 2022, get out into the community. Getting on Zoom is one thing, but getting out there and getting at I won't call it a road show, but getting out to more remote areas, community colleges, settings where we can actually hold public, I won't say hearings, but have members of the public have our deliberations on site in person, and invite members of the community to come to speak and give their personal anecdotes and stories about what works and what doesn't work and what they want. Because at the end of the day, that's what we're chartered to do, is to try to better the health of our fellow Marylanders. So I would love to aspirationally get out in the field, if you will. But for the purposes of immediately getting public comment during the latter parts of our sessions is something that we're going to build in, and just becomes a matter of, do we build in half an hour, 40 minutes every time we meet, every other, so that we reserve time for our deliberations. Even when we break into subgroups as we get to our work, that subgroup work is going to have to bubble back up to larger group, collective, and so. And we also just want to maintain some space for dialogue. So that's what we've been thinking. And Dean, I don't know if you want to add some additional commentary around that, but that's what we present to the larger group in terms of what we've forecast as a work plan.
Alex, if I may, I think you've captured it very nicely. We've heard some outstanding suggestions on sources of data that may be available, and so please feel free. We would like to really truly understand what evidence is available, and to the extent possible, engage those that are in areas that can provide insights and perspective that will help further advance our understanding of some of the challenges and barriers. Thank you, Alex.
As we enter into our closing 10 minutes, I still want to keep the dialogue going before I provide the kind of closeout comments and logistical points. So again, other thoughts that people have, comments, suggestions. We're working from a blank slate and we're starting to fill it in. Okay, as always, you know, you feel free to reach out to the co-chairs, the staff. The next meeting is task force, as I've indicated, will take place on Thursday, October 21st from 10 till noon. The topic of that meeting right now, we tend to have presentations from the Office of Oral Health, as well as the operations staff here at the department that administer our Healthy Smiles program, where you can ask some more of those granular questions. We will provide an agenda in advance of that, but we'll attempt to capture more data and also suggested work plan for the speakers and so forth. In advance of that, we will also send around draft of the different subgroups that we've been discussing today, and then create a mechanism by which to invite participation. I'm sure a lot of people have a lot of interest across a variety of different subgroups, but we are going to have to parcel the work out evenly. And so if that means a public drawing out of a hat, that may very well what we have to do, but we'll work on that and document that and memorialize that for you all. Dr. Romain, please.
I was just going to suggest, since we aren't going to meet for a month, might we use that time to share some articles? You know, so I would love to hear what somebody else is reading or what they learned, so we could come to the next meeting with some fresh ideas, or at least knowing what others are thinking. So I think to implement our Dropbox tool as early as possible would be really good, so we could just all know each other and what's important in our thoughts. And I think that would make for some great collaboration.
Diane, go ahead. If I may just interject, and Lindsay, I don't know if we've provided the link to the Google shared file, but if we haven't, we should do that, Dr. Romain. We have that set up, and your point is so well taken. It's an opportunity to help educate one another.
Yeah, Ellen, one of our support staff, is unable to make it today because she's ill, but we do have a Google Drive that's set up for all the task force members that will be shared just for you all. And again, we'd ask that we police that to keep it fairly tidy. We have the JCR in there. We have the presentations from what we have today. We will be more than happy to entertain meta-analysis from reputable sources and data that we can all look at, view as a library, a shared resource library for our task force. So that will be provided to you, and that will be a common workspace, if you will. For shared data. Presentations that were done today will end up in there, and so forth. So that has been contemplated and is actually in place, but we'll make sure that you have access to that. Any other questions, comments? Okay, remind everyone that we do have some time. We'll continue our deliberations and via email and send around various data that we're able to secure. At the end of the next meeting, we intend on opening it for public comments. If a member of the public would like to offer public comment to that meeting, Please contact Ellen, Lindsay, or Tyler with your email address by October 20th, the day before the meeting, so you can provide you with the Zoom login information. We will also plan to have a public comment session at the close of our December meeting as well. Again, the contact information is available via the task force website. I don't know if Lindsay or Tyler or Madeline can put that up in the chat box so that it's available for members of the public who may be listening to the Zoom can access. But that is in order to create as much visibility and collaboration with our fellow Marylanders and stakeholders as possible. With the 5 minutes we have left, Delegate Magnol, would you like to say anything in close as representative of the General Assembly?
I would just like to say I appreciate everyone giving your time. I know that that it's hard to carve out, but this is so important, and I think everyone in this meeting has a commitment to greater access for oral health care because they know the essential nature of it. It's not just about a pretty smile. It's about it's about your life. It's about your work. It's about your self-esteem. And I really appreciate the fact that everybody is giving of their time to get us better access in the state of Maryland. And I look forward to us being a leader for the nation.
Thank you. I've been informed by Lindsay that we can't see the chat box on YouTube, so that's shows my technological proficiency. I will make sure that everyone has access to the website and provide that so that people can be aware of our deliberations. Any other thing closing for the good of the order before we conclude? Well, again, to echo Delegate Magnol's sentiments, thank you so much for taking the time. Thank you so much for your participation. We have a large task in front of us, but something that's very exciting. And I know everyone's wedded to the idea of providing some great recommendations to the General Assembly. So thank you very much. And we will look forward to meeting you at the next meeting.
Thank you. Bye now.
Bye-bye.
Thank you.